Barbara Melchert, and I'm from the Department of Molecular Pharmacology of the University of Groningen. Today's date is March 30th, 2020, and this is a recorded class for the course Pathology and Immunology for first-year student. This class will be about one of the other obstructive lung diseases in addition to asthma, namely COPD. In the video about asthma, I already explained the difference between obstructive and restrictive lung diseases. So COPD is another one of the obstructive lung diseases in which it becomes difficult to exhale breath. So COPD stands for chronic obstructive pulmonary disease, and in Holland around 320,000 individuals have COPD and around 300,000 that have a high risk of developing it. The main cause in the Western world is smoking, but another cause that is coming up is exposure to air pollution, and especially in the less developed countries, there are a lot of people who develop COPD because of exposure to, for instance, biomass fumes that develop when cooking, or air pollution, like cities in China and India and South America that have a very high pollution, air pollution. People there also develop COPD because of exposure to those noxious gases. It can also be genetic when you lose production of, or you don't have production of an enzyme called alpha-1 antitrypsin, then you're at an increased risk of developing COPD. And the problem with this disease is that it cannot be cured. There is some treatment of symptoms, but you cannot repair the damages done by smoking or air pollution. So to stick with smoking, think about this question: what is the percentage of smokers that develops COPD? And the answer is 20%. But if you then look at the people who have developed COPD, how many of them have smoked? Well, then the percentage is 90%. So in Holland, almost all people who develop COPD have smoked. So what is COPD? COPD actually is a complex of several types of diseases, and the two main forms are chronic bronchitis and emphysema. So chronic bronchitis is, well, bronchitis means inflammation of the airways, so it's a chronic inflammation of the airways. And what happens is that the airways become inflamed, like in asthma, and the wall of the airways becomes thicker, the smooth muscle bundles contract, making the lumen of the airways even smaller, and there's lots of mucus production, making it difficult to breathe. Where in asthma, these episodes of contraction of the airways are temporary. In COPD, they are continuous. So there's a continuous shortness of breath and wheezing. Emphysema is slightly different. Emphysema is the loss of alveoli. What happens is that the alveoli get degraded, so these thin little walls get damaged, and this becomes one big loose sac. That means that you lose elasticity of the lungs. So these two ends of the spectrum of COPD, chronic bronchitis and emphysema, they also can be seen in people from the outside. So the people with that have mainly chronic bronchitis, we also call blue bloaters. They're usually overweight. They cough a lot because of the mucus production, and this end of the spectrum is also associated with congestive heart failure and other types of heart diseases. Whereas the people who develop emphysema, so the loss of alveoli, the damaging of the lungs, they also have other organs that get damaged. So they have loss of lung tissue, but also loss of muscles, and therefore loss of weight, and loss of bone tissue, so osteoporosis. And we call these people pink puffers. And because they develop emphysema, they have a very characteristic puffed up appearance that I'll talk about in a minute a bit more. So in COPD there are also sex differences. It seems like women are more susceptible to the harm of smoke exposure and have more damage to the lungs at a younger age. So they tend to develop COPD at a younger age when they smoke. And they also tend to have more exacerbations. And an exacerbation is a lung attack, and I'll talk about that in the next slide a bit more. So COPD was tended to be a male disease, and that's because there were differences in smoking behavior. So in the early 50s and 60s, 70s, men tend to smoke more than women, so there was more, as you can see here, more men smoking, and they tended to then develop a little bit later. So in the 80s, they tended, and the 70s and the 80s, they tended to develop COPD more often. But the smoking behavior of men and women is fairly similar now in Holland, and what you can see is that the prevalence of COPD is increasing in women, showing that they might be more susceptible to the harm of smoking, because there are equal numbers of men and women smoking now, approximately, while there are more women with COPD. So what is a lung attack, an exacerbation? Well, an exacerbation is the thing that kills most COPD patients. It's a very big clinical problem, and it's a rapid increase in symptoms and deterioration of the condition of the patient. It often results in death, and it's often caused by an infection, usually by a virus. So this could be flu or rhinovirus, and in these corona times, of course, people are very much at risk of developing exacerbations due to corona. But not all of the people who get an infection get an exacerbation. So it's very difficult to predict who's going to get the exacerbation and who isn't. And we don't have any treatments for exacerbations. So how bad are exacerbations? That's something I want to show with these two questions. Do you know the percentage of people that dies within 2 years of a heart attack? Think about that. Well, the answer is around 10%. If you then look at people who have COPD, do you know the percentage of people who die within 2 years of a lung attack, within 2 years of having such an exacerbation? Well, that's 50%. So if you have COPD, you're very worse off having lung attacks. It is a risk factor for early death, much more than a heart attack would be. So chronic bronchitis, it's constricted airways with lots of mucus, as you can see here, that make it difficult to breathe. And this mucus also is thick, and it's hard to cough up, so it's a nice place for bacteria to grow. So you have a higher risk of infections and then developing exacerbations. And the only way we can treat this is treat the symptoms. So inhibit the inflammation with corticosteroids and open up the airways with airway dilators like beta mimetics and anticholinergics. Emphysema is the loss of lung tissue. It's a breakdown of these alveoli, and there are several hypotheses why that happens. So basically there are three. There's the protease-antiprotease theory, the oxidant-antioxidant theory, and autoimmune disease caused by smoking. So the cigarette smoke induces an inflammation in the lungs. And the theory of protease-antiprotease is that there's an increased release of enzymes that degrade lung tissue, and that there's not enough production of proteins that can block these proteases. And the reason this hypothesis was thought of is because people who lack alpha-1 antitrypsin have an increased risk of developing emphysema. And alpha-1 antitrypsin is one of those antiprotease proteins. So it can inhibit the protease trypsin. Trypsin can degrade lung tissue and thereby cause emphysema. The other theory about oxidants and antioxidants is because cigarette smoke leads to the production of a lot of reactive oxygen species. You breathe them in, and the inflammation that the cigarette smoke causes also creates lots of reactive oxygen species called ROS. And to prevent these from hurting the tissue, you need antioxidants, and it's been shown in patients with COPD that they have lower levels of antioxidants. Then the third theory is that COPD actually is an autoimmune disease caused by smoke. So what happens with the smoking and with the oxygen species that develop is that proteins within the lung get changed, and these changed proteins are then seen as foreign, and the immune system will react to them and will set up an immune response against these foreign proteins, and then your immune system will respond to your own changed lung tissue. So what does emphysema actually look like? Well, this is a picture of a normal lung with all these tiny little alveoli, and emphysema is the loss of the alveoli, so you get big holes in your lungs. That means that there's less surface for gas exchange, and also because this tissue is fragile, you have a high risk of a pneumothorax because you might easily tear the membrane around the lung. Also, this means that you lose a lot of elasticity of your lungs. So this elasticity is necessary to push out air again, because you expand your lungs, and because of the elasticity, it collapses back when you breathe out. If that doesn't happen anymore, the air stays in the lungs, and what is very characteristic of people with emphysema is air trapping or hyperinflation. So the air stays in the lungs, it cannot leave the lungs anymore, and these people blow themselves up basically. So what you see in people with emphysema is a very blown up rib cage because the air cannot leave the lungs anymore. Here's a picture of what it looks like under a microscope. Here again, nice thin alveolar walls, nice small rounded alveoli, and here you can see that a lot of the alveoli are damaged and you get these huge holes in the lung. So what does this look like, this air trapping? Here you have normal lungs. If you breathe out, it should like this. The diaphragm is relaxed, so it pushes the lungs back, and the air leaves through the mouth. If your lungs are not elastic, the diaphragm doesn't have enough power to really push the lungs back, and there's air staying in the lungs. And you can see that in these pictures of transplanted lungs. You see all these air bubbles here, in addition, of course, to all the soot and stuff from smoking. So these bubbles, they're basically a non-functional lung tissue where the air cannot leave anymore. So how do you treat emphysema? Well, the most severe cases are treated with a lung transplantation, but of course we don't have a lot of donor lungs, so other types of interventions are tried out. So one of these interventions is lung volume reduction surgery, is that just to cut out the most damaged areas of the lung that are really not elastic anymore and have these huge bubbles. You can cut them out and thereby make the volume of the lung smaller in the hope to be able to exhale again. Two other ways of treating the disease is by placing one-way valves and by placing coils, and these two therapies are tried out in the UMCG. And I got some pictures from one of my colleagues from the UMCG who is really piloting these treatments. So here is the one-way valve. So what these pulmonologists do is put a valve into an airway, leading to a hyperinflated part of the lung. And these valves are one way, so the air can only go out, and if you breathe in, the air doesn't go to the hyperinflated part. So in the end, all the air will leave the area behind this valve, and the lung tissue behind it will collapse and start to stick together. So you get atelectasis, but in this case that's good because it means that you don't have this hyperinflation anymore of dead volume. And I have a little movie here that shows you how they place these valves. You can see here a bifurcation, two airways. So just before those two airways, the valve is placed, and here you can see that it only opens up at certain times and the patient is exhaling. So the air leaves the lungs, but it cannot go in anymore. So what is the result? So here's an X-ray of a rib cage, and here you see two very hyperinflated lungs, and this lung is treated, and you can see here that after the treatment it becomes a lot smaller again, whereas the non-treated lung is still very big. So another way of treating this hyperinflation is by making the lung elastic again by adding these coils. So these coils are placed into lung tissue, and they're sort of grappling the lung tissue, and when you inhale you will put pressure on this coil, and the coil will try to get back to its original form and taking the lung tissue along with it. So here's a picture of a patient treated with these coils, and you can see you need a lot of them in the lung, just to grab all the lung tissue together and make sure that when you inhale, these coils are tensed up so you can exhale again. So these are all possible treatments for emphysema, but the best therapy of all is to quit smoking, because in Holland most of these people will have smoked. And here you can see what happens when you smoke. So this is again lung function, age, and as I told you before, lung function declines when you age. That is a natural phenomenon. But if you smoke and you're susceptible to the smoke, your lung function declines rapidly. But if you stop smoking, so if you stop smoking here, what you can see is you've lost lung function. But after you stop smoking, the lung function decline basically is similar to a healthy person. So you may have lost some lung function, but you can stop that accelerated decline in lung function. So to show you that there are other benefits of stopping with smoking, I have a little movie that is shown here.
We all know that smoking is bad for you. There's even a possibility that there was a horribly frightening advertisement before this video featuring some person who talks through a hole in their throat. You shouldn't smoke, and you know the reasons why. Or do you? There are, in fact, some really surprising and weird reasons not to smoke in addition to all of the normal horrible ones, and we're going to talk about a few of those now. Number 1. Smoking makes your boobs sag. That's right, boob sagginess is a real scientifically studied thing, and among the risk factors are being overweight, having larger breasts, having babies, and smoking cigarettes. Things that do not affect boob sagginess, whether or not you breastfeed, weight gain during pregnancy, and lack of upper body exercise. So now you know. 2. Like listening to music, watching movies, hearing things. Smokers are 70% more likely to develop hearing loss than non-smokers. Even worse, development of hearing loss in smokers happens much earlier than in the general population. Smokers start losing their hearing in their 40s or 50s instead of their 60s or 70s. Number 3, if you're not worried about saggy boobs because you don't have any boobs, allow me to scare the cigarette right out of your mouth. Men who currently and formerly smoked were about 30% more likely to suffer from impotence. So while you, and maybe even your lady friend, might think that that cigarette sticking out of your mouth makes you look super sexy, it's not gonna matter if you can't get it up. 4, if you don't care what you look like or whether you can get it up, and you don't have any kids and you live alone with a bunch of dogs and cats, think about their health. Secondhand smoke has been proven to cause nasal and lung cancer in dogs and malignant lymphoma in cats. This might seem inconsequential when compared to the human health risks, but 37% of smokers said that clear evidence that smoking was bad for their pets would motivate them to quit. And finally, number 5. You like being happy? In a study of more than 7,000 adults, smokers were found to be less happy than non-smokers and ex-smokers who had quit more than 1 year previously. Healthy body, healthy mind, I suppose. Too bad those things are so freaking addictive. My strategy, which has worked for me thus far, is to never let one of those things anywhere near my mouth. I suggest you try it too. Thank you for watching this episode of SciShow. If you have any questions or ideas for future videos, please leave them down below in the comments, or you can get in touch with us on Facebook or Twitter. And if you want to continue getting smarter with us, go to youtube.com/SciShow and subscribe. We'll see you next time.